So again, welcome you all for today's session. As I was mentioning, delirium is a very, very important topic. We see a lot of patients in delirium when you start working in a palliative care setting, like at various stages of illness, starting from the correctable stage or the reversible stage of illness till the terminal delirium. And it is very, very distressing symptom for the family as well as for the patient. So that's how it becomes so important to understand what it is and how to manage delirium in a palliative care setting. So today we have as our faculty Dr. Megha. Dr. Megha is a senior consultant in Max Hospital, Delhi. She is an anesthetist by training, but she's trained in palliative care from Cardiff University, and she has around 11 years of experience in this field. And she has a specific interest in cancer pain management as well as end of life care. And I understand they do a lot of palliative care and cancer pain management in Max Hospital, Delhi, along with her anesthesia background. Welcome you, Dr. Megha, for another session with us on delirium. Thank you so much for agreeing to be a part of this group.
Thank you so much, Dr. Sridevi. Thank you so much, Team Pallium India, for organizing such sessions. And I feel this is what is required, to make people understand the importance of such topics and how to manage it specifically in palliative care settings. Thank you so much for arranging these sessions. May I share my screen, please?
Yes, ma'am. You have access.
All right. Thank you so much, Dr. Sri, for that kind introduction. And so what is delirium? First, let us understand. I'm sure we have many doctors here in this forum who are attending this. So many of us know a little bit about delirium. We'll start with that thought of what is delirium. Delirium, oops, just give me one moment. I'm sorry. Off the track or to go out of the furrow, right? So there are many instances, that I'm sure we all have seen delirium in one form or the other. Say about a 55-year-old male chronic alcoholic in liver failure who's admitted with hematemesis. And in the ward, he shouts, abuses, becomes restless, pulls out his IV lines. This is one scenario. Then a 60-year-old lady who is a known diabetic on insulin and is found in state of lethargy. Or a 40-year-old female with carcinoma breast who has had surgery and chemo, and in one fine morning, she's found in a state of disorientation, says that there are a lot of lions in the room staring at her. So it is a neuropsychiatric symptom, right? Let us move on to two important aspects, right? Which is, one of them is consciousness. Right? Consciousness. Many times we just casually say the patient is conscious oriented, right? So when the patient is conscious, there are three important things that we are looking at. One is awakeness, that the patient is awake. Second is alertness, right? So many of you might be awake at this point. However, you may not be alert. So then the third and very important is awareness, that you are also awake. You're also alert. However, whatever I'm speaking, you are just listening it and may not be registering what I'm saying, right? So you might not be aware about it. So awakeness, alertness, and awareness, that's consciousness. Another thing is cognition. Cognition is the internal structures and processes that are involved in acquisition and use of knowledge, right? Including sensation, perception, attention, learning, memory, language, thinking, reasoning. So all this is combined as one term, which is cognition. So these are two very important terms, consciousness and cognition. And what is delirium? Delirium is characterized by an acute change in cognition, right? And a disturbance of consciousness. okay, usually resulting from an underlying medical condition or from a medication or a drug withdrawal, right? So the important thing is it's an acute thing. Delirium is acute. There is change in cognition, disturbance in consciousness, and there's almost always there is some underlying medical condition or cause, can be medication or drug withdrawal, that is causing the delirium, right? And it is not uncommon. It happens in more than 80% of cancer patients near death. However, it's not only in cancer patients, we'll come to it. Delirium is also an indicator of poor prognosis and end of life care, but it does not only happen in cancer patients. They say that 10 to 20% of all the hospitalized adults, they develop delirium. 30 to 40% of elderly hospitalized patients, they develop, because old age is an important predisposing factor. Then 80% of ICU patients, हम ICU psychosis बोलते हैं ना, जिसको ICU psychosis हो रहा है. So 80% of ICU patients do develop delirium, है ना. So again, ICU change of place is again a predisposing factor. So how do we diagnose delirium? There is a Diagnostic and Statistical Manual of Mental Disorders, DSM-5, this diagnostic criteria. The first and important thing in this is that there's a disturbance in attention, that is reduced ability to direct, focus, sustain, and shift attention, and awareness. So disturbance in attention and awareness, reduced orientation to the environment. Then there is a disturbance that develops over a short period of time. These are all what I said already in the definition of delirium. It's an acute thing, so it develops over a short period of time, over hours to few days. It represents a change from baseline attention, like a few days back or a few hours back, the patient was not like that, right? So change from baseline attention and awareness, and tends to even fluctuate during the day. Like morning, he was okay. Towards the evening, patients become more delirious, right? Then an additional disturbance in cognition, as we said, it's also cognition and consciousness, both the things. Like cognition may, as we heard in the definition, memory deficit, disorientation, language, visual spatial ability, or perception. And the disturbances that we said in criteria 1 and 2 are not better explained by any other pre-existing, established, or evolving neurocognitive disorder. And they do not occur in the context of severely reduced level of arousal, like comatose patient. We cannot call a comatose patient as delirious, right? And there should not be any underlying things like a patient who is already schizophrenic or known such things, so or dementia. So we need to differentiate these two. Then the fifth important criteria for diagnosis of delirium is that there is evidence from the history, physical examination, or laboratory findings that disturbance is a direct physiological consequence of another medical condition or substance intoxication or withdrawal. That is because of drug abuse or medication or exposure to a toxin, that there is always an underlying etiology to it, right? So it is an acute confusional state with mental clouding, poor concentration. There is impairment of short-term memory, disorientation can be there. There can be misinterpretations, paranoid delusions, hallucinations, agitation, incoherent speech, aggressive behavior. All these things can be there. And clinically, how does delirium present? It is not always hyperactive. It is not. We always think that the patient is aggressive, only then it is he's delirious. Many times it is hypoactive. The other day, Dr. Sri also shared a very important anecdote that she experienced in her while she was dealing with her patients. So that many times if the patients are hypoactive, they do not talk a lot. So we think they might be depressed or just they are withdrawn. However, that is another form of delirium, and more commonly it is also mixed delirium. So hyperactive, they present with psychomotor agitation, increased arousal and delusions. The degree of cognitive impairment may be variable and even minimal. Hypoactive, that the patient is withdrawn, lethargic, and there is reduced arousal. And there is mixed delirium, that they present with both hyper and hypoactive. So why is delirium unrecognized or misdiagnosed, or it is even mistaken for dementia, depression, mania, acute schizophrenic reaction, or just as a part of old age. So we need to differentiate between all these very commonly seen problems, and we need to differentiate so as to provide appropriate management. I've already told, but I'll still say that again. Fluctuating levels of consciousness and decreased attention, disorientation, visual hallucinations, agitation, apathy, withdrawal, impairment in memory and attention, acute onset, right? Acute onset, and there's always some underlying problem. Okay, so this is important in delirium. However, when we talk about dementia, there is always memory impairment. There can be disorientation and agitation in dementia too, but it is always chronic, slow onset, progressive, right? So the history would tell that the patients have been like that. They have had such episodes earlier too. Then depression, sadness, loss of depression. In depression, patients are sad. They have anhedonia. Anhedonia is loss of interest and pleasure in the activities that they used to enjoy earlier, right? Disturbance of sleep, appetite, concentration, and energy. Feelings of hopelessness, worthlessness, thoughts of suicide, and single or recurrent episodes. This again, depression may also be chronic. So psychotic and then psychotic disorders, deficits in reality testing. Usually they are slow onset with prodromes, and they are again chronic with exacerbations like schizophrenia and those. So what are the implications of delirium? As Dr. Sri was already saying, that it has huge implications on the patient, on the family, and on the staff. So we'll just touch upon these things. These are very important. So interference, when we say about patients, they are not able to communicate. The time loss, of course, and then there are increased investigations. If the patient is delirious, we'll first rule out the organic causes. If it's a cancer patient underlying, so we have to rule out if there is any brain metastasis. If it's an old age patient, we have to rule out any kind of hematomas, SDH in patients. So increased blood tests and CT scans, increased interventions like IV line, opioid changes, and sedation. Then it prevents patients' participation in treatment decisions. It also makes assessment of other symptoms more difficult. It interferes with communication between patients and their family. Families find it so, very difficult to deal with such situations. The patients, the loved one that they knew, they are not the same anymore. So it's really disheartening for the families to see their loved ones in delirious state. Families find, so they find their changes very distressing. These changes very distressing. There is difficulty in interpreting symptoms. There is conflict with relatives, and there is increased stress, of course. Then there are risk factors, as I was already mentioning: old age, male sex, then hypoxia. If the patients are hypoxic, they tend to become delirious more often. Dehydration, cachexia, opioid use, anticholinergic burden, and ECOG performance status. So, yeah, and of course, change in environment. As I said, why is it more common in ICU? Because the environment is very different. There is no orientation about day and night in ICU. So change in environment, unfamiliar stimuli. If we are not telling the patient and keep on pricking them for blood samples and repeated IV cannulations. So unfamiliar stimuli, it's too hot, too cold, wet bed, and creases in the sheets. So anything that is distressing might lead to delirium. Okay, so what are the causes? Fecal impaction can itself lead to a delirious state, pain, urinary retention, infections, dehydration, brain tumors, hypercalcemia. Many electrolyte disturbances can cause such problems, hyponatremia, drug-induced like opioids, corticosteroids, anticholinergics, then many chemotherapeutic agents, including cisplatin, 5-FU, and methotrexate, then withdrawal state of alcohol, nicotine, or psychotropic drugs. Thiamine deficiency can also cause delirium. Delirium is frequently underdiagnosed because we fail to screen for it, isn't it? Many times we just let it go away without even screening the patients for it. So delirium assessment tools are very important and they're very simple. However, it does take a little time and effort to do them, but they are not very difficult to do. MMSE is very common. We've been reading it through our MBBS days, mini-mental status examination. Then there are specialized scores like Memorial Delirium Assessment Scale. There are CAM and other scales too. We'll discuss just these two. So mini-mental state examination is, it's a 30-point system, okay? And in which we have to give marks for each aspect that we assess. I'll just give you a little thing about how to do it. So like orientation, we are whatever we have learned about delirium till now, the same things we are going to examine here in MDS or in MMSE, right? First important, just give me a second. So MSE is in this we are going to assess about the orientation. There are 5 things about time and place for each. 5 things about time, as in what is the year, season, month, date, and time, and give for each correct answer, patient gets 1 point. Okay. Then about the place, which country are you in, town, district, hospital, ward, or floor. 5 questions, 1 point for each correct answer. Registration, then you will tell 3 objects to the patient, say any 3, apple, table, money, and ask the patient to repeat, right? So 1 point for each correct object that the patient is able to repeat. Then we will also ask the patient to remember these 3 words, and in the recall section of MMSE, we will come back to that. Then attention and calculation, right? So tell the patient to subtract 7 from 100 and keep on doing it for 5 consecutive times. Or you can even tell a word and ask the patient to spell the word backwards, right? So that's about attention and calculation. And again, give points 1 out of 5. 1 for each correct answer. Then recall, ask the names of 3 objects that you told earlier. In language, again, there are a few aspects that we see. First is naming. Okay, ask the patient to name any 2 objects. If they are able to tell, they are given 1 number for each correct answer out of 2. And repeat. Tell them to repeat the 2 objects, and they should not be saying any if, but, those things. So if they're able to clearly repeat 2 objects, they get 1 point. Naming, repeating. Then another is for following the commands. Okay, give a 3-stage command, and they get score 1 for each stage. Place index finger of right hand on your nose and then on your left ear, right? So this is how, that's a 3 thing command. Out of 3, patient will get the score. Then you have to assess reading, that give a command in the writing and patient has to read. Then another aspect that we see is writing. Ask the patient to write a sentence. It has to be a legible and a sensible sentence. Then copying or drawing. Ask the patient to copy a pair of intersecting pentagons, and they need to copy it. They get 1 mark. So in this, I'm sorry. So 24 to 30, if this score out of 30 is 24 to 30, no cognitive impairment. 18 to 23 is mild. 0 to 17 is severe. So lower the score, more the cognitive impairment. That is mini-mental state examination. Simple to do. You can have a copy of this and do this, right? Then another important, very commonly used tool for delirium assessment is Memorial Delirium Assessment Scale. So again, the things that are being examined are just the same in one way or the other. There are 10 items in this scale that we examine, and we give a score from 0 to 3 for each item. There are a few things that we have to formally ask, and there are a few 3 of these things that we are just observing and observing while we are conducting this interview. So first is item 1 is reduced level of consciousness, or we are assessing the awareness here. So you ask the patient to describe their surroundings. Okay, so 0 to 3 in this score, higher the worse, right? So matlab 3 score is given when the patient is more delirious or less aware here in this point. So 0 is the normal, none, no abnormality. Patient is fully aware about the environment. 1, 2, 3, mild, moderate, severe. Right? Severe means that the patient is unaware of all the elements in the environment. They are not able to spontaneously interact or awareness of the interviewer. So it is not really, even when the interviewer is again and again telling and asking them, they are not able to connect to their environment. That's item 1 about awareness. Item 2 is orientation. Again, 10 orientation questions. They are very similar to the ones that we used in MMSE also. And we give marks or score on the basis of how many items the patient is able to tell. 0, 1, 2, 3. Then short-term memory impairment, repetition and delayed recall. Immediately repeat and then recall after 5 minutes. Again, here again we give 3 words and the patient needs to tell them, repeat, repetition, and then after 5 minutes again you'll ask them to repeat. 0, 1, 2, 3. Then impaired digits, digit span. Digit span, if you guys are aware of this test, it is commonly used for dementia and delirium assessment. So it is like give them first we give 3 digits, something like say 3, 4, and 8. 3, 4, 8. So they have to repeat. I as an examiner will say 3, 4, 8, and it with a 1 second gap, right? And then the patient has to repeat 3, 4, 8. Then I say 4 digits, say 7, 9, 2, 4. Patient has to say 7, 9, 2, 4. Similarly for 5 digits. And then we do that backwards, that the patient has to repeat my digits backwards. Okay, and we see if the digit span is impaired or not. Again, we give a score of 0, 1, 2, 3 for mild, moderate, and severe limitation. Then we have reduced ability. We have to observe reduced ability to maintain and shift attention. That questions need to be rephrased. They need to be repeated. Patient attention wanders from here and there. And the moment, if there's any sound around for anything, the patient's attention shifts there very quickly. So all these things, patient is distracted or over-absorbed in a task. So these things we need to observe while we are conducting this interview. We are not really asking the patient this, we are just observing this. So again, 0, 1, 2, 3 for mild, moderate, severe. And disorganized thinking, again, we need to observe this: rambling, irrelevant, incoherent speech, tangential, circumstantial, or faulty reasoning. And so you can also ask the patient to describe their current medical condition and to know how much is the patient, organized in his thinking. Again, 0, 1, 2, 3. Then perceptual disturbances like misperceptions, illusions, hallucinations, inappropriate behavior. Again, we have to observe this. 0, 1, 2, 3. Delusions, inappropriate behavior during the interview or admitted by the patient. Again, 0, 1, 2, 3. Then decreased or increased psychomotor activity, hypoactive, patient is hypoactive, hyperactive, or both the elements are present, right? And we have to observe the sleep-wake cycle or disturbance of the patient. You can ask the patient, and especially when we are observing in the morning, the previous night would be important. And we can ask the nurses, family, patients, and see their charts to observe this. Right. So a total of, again, it's maybe the score is total 30 and 13 out of 30 is the cutoff point. Like more than 13 score means delirium. How to do it is, again, as I told you, it's done in a similar way. Ask about orientation in place, time, and person, short-term memory, digit span, hallucinations, delusions, hypo or hyperactive sleep, and observe for level of consciousness, disorganized thinking, focus, sustain, or shift attention. Then coming over to management. Correct the correctable. There's always an underlying cause when the patient is delirious. Find the cause and correct it. Non-drug treatment, very important, I'll come to it. And drug treatment. So causes, which we already discussed, focus on them. We in palliative care have kind of, most of us, follow something like advanced symptom assessment score, or some other. We have made our own modifications of such symptom assessment scores, where so these are very important, pain, constipation, urinary, have you passed urine? So all these things, and we always let the patient open their mouth, have a look into that. So to assess for hydration, fever. So all these symptom assessment is very important, and we get to know a lot of things by our regular symptom assessment, which we do in palliative care in our daily rounds. So all these things we can get hold of while we are conducting our regular examination of the patient. Fecal impaction, pain, urinary retention, infections, dehydration, brain tumors. Then, of course, if the patient we suspect, getting electrolytes done is a good idea. Hypercalcemia, hyponatremia, drug-induced, opioids, corticosteroids, anticholinergics, chemotherapeutic agents like cisplatin, 5-FU. So 5-FU causes a lot of diarrhea. So electrolyte disturbances and those things, dehydration. So it's very important. And methotrexate. Then withdrawal state, we have to have the history of alcohol intake, nicotine, or any other psychotropic drugs, or thiamine deficiency. Non-drug treatment, I feel this is so underutilized when we are dealing with delirious patients, and we as doctors and our nurses have a huge role to play in non-drug management. I cannot overemphasize this a part of delirium management. And I myself keep making our nurses understand the importance of this, but nurses keep changing, and we need to keep doing that all over again for them. So tell the patient and family that delirium is not madness. Caregivers are really distressed with this symptom. We need to take care of the caregivers, tell them that this is okay, we will make this better, this can become better. Continue to treat the patient with courtesy and respect. Many times the physician will not stop talking to the patient and will only consult about the symptoms also to the family members, and listen more to the family members, ignoring the patient completely. So the patients, as such patients, need to be told about their disease, about their symptoms, and that we understand them. No restraints, no physical restraints ever, even in hyperactive delirium. If required, we can have chemical restraints with some medications that we'll discuss, but no physical restraints. That will only worsen their delirium. And patients should be allowed to walk, but accompanied. They many times in the hyperactive delirium, they are restrained to bed and they are not allowed to move, that they might harm themselves or someone else. So be careful, but they should be allowed to walk around. Explain every procedure and event in greater details rather. Sometimes we think that they don't understand that unko samajh nahi aa raha hai. So we need to explain and explain all the procedures. Presence of a close family member, just like we do for pediatric cases, that let the patient be placed in their mom's lap for an IV cannulation. So similarly, the presence of a family member is really helpful and to calm them down. Doctors can acknowledge the patient's distress. I can see that you are really upset, and that really helps. Orientation protocols, they must be in place, especially in ICUs and even in the wards. Orientation protocols, like whenever nurses or we as doctors go and visit the patient, meet the patient, reorient them as to okay, I'm Dr. Megha and I'm your palliative care physician, and it is 12 noon. I have come here to ask you about your pain. So something of that sort, just orient them to the time, place, and person. You have been admitted with this problem in our ward. What do you think? How are you doing? All those things. And having a calendar, clock, family photos, it's very important. Environment should be stable, quiet, well lighted. Support from a familiar nurse or family should be encouraged. That during the day it should be bright, during the night the curtains should be down and the lights should be dimmed. So this helps the patient to orient themselves to day and night. Family members and staff should explain the proceedings at every opportunity, reinforce orientation, and reassure the patient. Very important, very important. Sensory deficits, like if the patient uses their spectacles or a hearing aid, they have to, we have to provide them with those that helps them orient themselves to the time, place, and person. However, sometimes we do need some drug treatments. If the patient is able to take orally, there are many agents like haloperidol, mirtazapine, quetiapine. And haloperidol is one agent that is also available in IV form. So we can give, start the dose of 1.5 to 3 milligram orally, or 1 milligram subcutaneous, or IV 8 hourly. So, however, haloperidol, quetiapine, all these drugs also cause QT interval prolongation. So we get a baseline ECG done before we start these medications. And they are helpful to the patient, but along with non-drug treatments. Right? Then mirtazapine is one good agent that we use commonly. Then quetiapine is one good agent. They also help to, reverse, if the help change the reversed sleep-wake cycle. The patient sleeps well at night, and then that's why we mostly start these agents at night. And most commonly, delirium also happens during the evening times, and it worsens during the evening and night. So we do that. Again, review, and review. We need to find the cause of delirium. The patients do not get delirious just like that, right? So, and many times there are multifactorial causes. It's not just one thing, like the patients have raised bilirubin. They are also going into hepatic encephalopathy. There can be deranged electrolytes. There can be deranged kidney function tests. And along with that, the patient is, suddenly shifted from home to ward or to ICU. All these multifactorial things also add up. So review, and review. Very important to find the cause and keep helping the patients with non-drug treatments too. And to summarize, it is underdiagnosed, it is misdiagnosed, and we need to screen for it. Only then we'll get to know about it. In cancer patients, many times it is definitely one thing for poor prognosis. It signifies that correct the correctable, non-drug treatment and drug treatment. Thank you so much for your cooperation and for your time. Thank you.
Thank you, Dr. Megha. We'll take up a few questions. We have time for discussion.
Absolutely.
Are there any questions from your side, from participants? Please unmute or type it in the chat.
Can I speak, ma'am?
Yes, please.
Ma'am, generally all the assessments that we do, if a patient is bedridden or is generally not able to speak, then the assessment will be subjective based on the professional assigns a score, or should we be asking the caregiver if the patient cannot clearly communicate?
So the question, if I'm getting it right, that if we cannot do all this formal assessment with the patient, can we ask caregiver's assessment? Yes?
Yes, ma'am.
So if we cannot really do this, then caregiver's assessment would be one proxy thing that we can utilize. However, many times just talking to the patient, even if we are not able to, formally do this entire assessment in terms of digit span or recalling and naming the objects, many times when we are just talking to the patient and, talking to them about their disease, about their symptoms, many times we get those subtle things about if they are oriented, if they are, attention span goes haywire, are they if they are, they have some delusions or hallucinations, such things do come out when we are just talking. So importantly, talking to the patient is very important here. Caregivers, yes, they at that time the patient may not be delusional. However, the patient might be saying some things of that sort to the attendants while we were not around. So yes, their inputs might be helpful.
One more about how do we differentiate between like ASIS-4 rather, hypoactive, delirium, and depression? Because generally when a person has an illness, they tend to be naturally withdrawn at times and feel sad and do not communicate as such. How do we?
So here the major difference would be orientation. The depressed people are well oriented to, they know what is happening around, right? They may not express. And however, when we talk to the patient, they may not be aware of what's around, disorientation, asking them simple questions. Where are you? What time do you think it is? Simple questions like those would be able to help us differentiate. Plus, history of depression might be one important aspect here.
No formal questionnaires or anything. No formal questionnaires also, right? I mean, just the MMSE and MDL.
We have depression questionnaires like PHQ-9 and those things. So they can be used. Dr. Sri, are there any particular questionnaires to differentiate between depression and delirium? I'm not aware of them.
No, I'm not aware of that. As you said, the orientation will not be affected in depression. I'm not, there is a chat called CAM scale. Dr. Ravi, would you like to just talk about it, like whether it differentiates between hypoactive delirium and depression?
Ma'am, it has parameters regarding the alertness, consciousness, everything regarding during the interview, post-interview with the patient. I actually can't remember the entire parameters, but it's really helpful in confusion, and it definitely differentiates between delirium and depression. My seniors have used that scale, but I haven't much experience with it. My seniors have used it, CAMS, and in ICU patients and in some other non-verbal patients, they use the RAS scale, and that differentiates. Yes, that definitely differentiates between this. It has helpful. Once I have used, I'm not much experienced with CAMS scale, but it has the parameters to have all such things.
Is there any relation between the longevity, like what you can say, delirium is acute or short, depression is can we categorize in that?
Go again with your question.
Now what I am asking, whether depression is the long-term assessment, long-term, and
yes,
delirium should be, that's what I was asking, whether is some relation like that?
No, depression is not delirium for sure, right?
No,
However, when we are differentiating, delirium is mostly acute onset, and depression would be a more chronic thing.
And you expect delirium to last long, or what about that the timing, no? Whether it can come down immediately within 1 or 2 weeks, or it will continue. Depression, of course, we know it takes time to come back, no? So delirium,
delirium by improving the underlying causes, but sometimes the causes are say if the patient is in hepatic encephalopathy, then delirium stays, so depending on the underlying causes, the delirium would be short term, if it will be corrected ever or not. I think underlying cause would determine that.
That is treatable, that I understand. Only thing, otherwise old age people, they also get sometimes delirium like action. Is it so? I suspect so. So whether that how you'll be able to manage with these medicines only?
Medicines, orientation protocols, as I mentioned, for especially old age people, they need to be oriented again and again.
Again and okay, again. Repeat a sensitive session.
Oh, yes.
Thanks.
Dr. Shrikant, please.
Unmute yourself, please.
Sorry. I've used the delirium rating scale once or twice, I think, so on 14 measures, which span thought process, attention, and motor activity, sleep-wake cycle, and that elicits fairly usefully. And one thing which I was told by my professors once to differentiate between delirium, depression, and patients with dementia is that the temporality of the events that are happening in terms of when you are having the interview with the patient, whether what is the level of alertness during, whether there's any variability in their level of attention and response, the arousal and the attention during the course of the interview as well as on questioning with attenders. That was one thing that helps to differentiate between these three different components. If I'm not sure if that's what I've been told. So that's my take on that.
Thank you.
Any other questions? Any comments on management that you want to make? Because many of you might be seeing delirium in your setting, even in ICU setting, and generally people do start managing with benzodiazepines. That's the routine that I have seen most often. So, what is the practice that you follow, or anyone would like to have a comment?
So just can I make a comment?
Yes, Dr. Shrikant.
Yeah, just a few days back, we had a stroke patient who had went into sepsis and got shifted to the ICU, then became delirious after probably 4 days there. Of course, he had renal dysfunction because of the antibiotics, but then that also started dropping. He was still delirious. So we had him shifted out from the ICU to the ward as soon as he became stable. And we got the family members to keep going into the ICU and keep talking to him. So there is a study being done, automated voice messages given by family members when they can't visit. So sometimes reorienting them in terms of where they are with family intervention, family talking to them about where they are, what is happening around, because sometimes they might pull out tubes, tell them why the tubes are there. And as soon as they are stable, shifting them out, trying to alter the sleep-wake cycle, addressing the sleep-wake cycle, cueing them in the daytime, keeping them awake, wheelchair mobilization, trying to get them to spend as much time in natural light as possible. If there's a room facing the window or there's a balcony, all these tend to help over as non-pharmacological measures, along with antipsychotics to some extent, and help to hasten the process from a few, from probably a week and cuts it down by a few days. That's what I feel.
Absolutely, thank you. That's a very good. So there is a question from Dr. Ariba. Sorry, I missed it, Dr. Ariba. Good that you pointed it out. So suppose if it is an opioid-induced delirium, would you like to stop opioid, or how will you manage the pain then?
Right. So if we feel that we have ruled out other things and it might be opioid related, in that case, we will not really stop it. We may go down a little. Say if the patient is on 60 milligram of morphine in 24 hours, we may go down on the dose, maybe half it, and then assess again, or skip one dose and assess again. However, we will not really stop the opioids entirely. No.
So Dr. Vikram is mentioning about dexmedetomidine. Agree that, but maybe in a hospital setting, when you come to the community, it might be difficult, but it is a very good drug to be used in a hospital setting. But I have my own reservations because it's very expensive. So we have used it like in 1 or 2 occasions where people could not afford it more, but we could not use haloperidol due to some issues that patient could not tolerate haloperidol. But those cases we have used, but then it's damn expensive. And in a hospital setting, we could not send the patient back home. So Dr. Ravi has mentioned a few points, especially in patients with severe hyperactive delirium, combination of IV midazolam and haloperidol, because I asked that question, what do you use? So I thank you for that. And Very important point, not to argue with the patient when they are delirious. That caregivers do that a lot. Like in my own family, when my uncle was delirious, the aunt was trying to explain him things. Like he could not recognize her. He had dementia also with a terminal delirium. So then he kept getting scared, and he could not recognize people. So every time she used to explain things again and again, then it ends up in arguing, and then she ends up in crying that I can't convince him anymore. So it's very important to be with the caregiver and tell them, like, very valid point, Dr. Ravi, to tell them not to argue. You can reorient them, but then they go too much into reorientation that they want to actually reorient. That might not happen. So that's a very, very good point. And avoiding physical restraints, I totally agree, Dr. Nithi. And if you go to any ICUs or casualty, at least you will find a few of them being tied to the hospital bed, at least a few of them, because they are pulling out trials too, because they are pulling out IV lines, and there might not be any medications in their chart. So that's avoiding physical restraints. Please, please, all of you present here. It's very traumatizing for the family because people, so they might have lived a good life and suddenly they are now tied to the hospital. It's very, very traumatizing. So, yeah, thank you so much for that. So there is a question, how do we manage delirium in a patient in a home-based service where patient is not taking opioids and not willing for any investigations? Any response, Dr. Megha?
Yeah, so in that case, if rule out any causes, something like constipation or anything, just make them neat, clean, and in that case, I think drug management should be provided, and explaining them all the pros and cons, and drug management, something like haloperidol or quetiapine, I think may be used in such scenarios.
Maybe because of the delirium, they might not be willing for any investigations. They might want to be like so adamant. They don't want to do this, that. But once you control, as she was mentioning, start a drug and then you can control a little bit, they might agree to go for investigation. And even the investigations, when we say investigations, not really high-fi investigations, like she just mentioned, just take care of the constipation, bowel, bladder, reorientation. I think the key is to identify the cause and reversing the reversible. That is the key in managing delirium. And like thinking about each and every cause, what might be the possibility, and reevaluating. Most of the times we'll come to something like a hyponatremia or something like an anemia, something very simple and correctable. So that is the key. And non-pharmacological measures and talking to family so that they are not really traumatized. So is it acceptable to sedate the patient instead of restraining until the patient can be managed non-pharmacologically gradually?
So if we know that the patient is delirious and not just restless, in that case, rather than sedating with benzodiazepines, we would prefer antipsychotic drugs, like all these drugs, haloperidol, mirtazapine, or quetiapine. All these also have sedating effects. So we can use those drugs, but not benzodiazepines. That because benzodiazepines may actually, precipitate more delirium. So we're not really sedating. The primary thing is not sedating the patient. The primary thing is managing the delirium. So as as a doctrine of double effect, the other effect might happen, and but that effect was not intentional.
Thank you.
So we can give that, yeah.
Maybe if there are no more questions, we'll just start with the case presentation and we'll take a further discussion.
Yeah. I'll stop sharing.
Dr. Sharwan?
Hello, madam. Am I audible?
Yes, sir, you are.
Good evening to all. I am Dr. Saravanan. Here is our patient, 87 years old male, who is a known case of COPD with carpulmonale, now presenting with delirium, pneumonia, and hyponatremia. Presenting complaint. Fever and disorientation for the past 2 days. Having cough with breathlessness. History of illness. He is a known case of chronic stable COPD with carpal pulmonale for the past 35 years and had 1 to 2 exacerbations per year and on regular medications. He developed mild fever with cough 1 week back. And he was put on short course of steroid and antibiotic for 5 days. His SpO2 is 90 to 94% with atmospheric O2 and on domiciliary care, not willing for inpatient care. Developed mild disorientation, disturbed sleep pattern, reduced water intake. On examination, he is delirious, hypoactive with breakthrough hyperactive. That's mixed. His temperature is 90, pulse rate 100, blood pressure 120/70. His respiratory rate is 24 per minute, SpO2 90 to 94%. Cardiovascular system, SP2 is loud. On auscultation, bilateral V's with fine crack is present. Regarding investigations, his serum creatinine is 1.6 and sodium 128. His CRP is 22. Procalcitonin was 1.2 1 week back, reduced to 0.1 after completion of antibiotic course. Other parameters are normal. Regarding treatment, he has been taking glycopyrronium with formoterol as dry powder inhaler twice daily, budesonide 200 microgram as dry powder inhaler, tablet sildenafil 10 milligram OD, sildenafil citrate 20 milligram BD, acetylcysteine 200 milligram twice a day, toloptan 15 milligram of tablet OD. His psychosocial aspect is 87 years old male living with his family members in a sound socioeconomic condition, but he is depressed due to disease burden and frailty. He is a person of prime importance in the family. The main concern here is delirium and frailty. Summary. Here is a 87-year-old male having COPD with acute exacerbation, hyponatremia with delirium. Discussion point today is, do we need to prolong his life with aggressive measures like correction of electrolyte, ventilatory supports? But his SpO2 is above 90 and no signs of increased work of breathing. But in corporate setup, he may be put on ventilator. If we opt for a aggressive treatment, what are all the problems going to face by the patient and the family members? What all can be done for the patient and his family member as a palliative care physician? Thank you.
Thank you, Dr. Sharvanan. I'll just ask from the other participants for their comments.
In my opinion, like
Yes.
you can treat the patient for that electrolyte imbalance. Nothing wrong with that. These are all very cheap, affordable, and as a doctor we can try also. But when the oxygen level is more than 90-100, that is a question of putting in ventilator. That also doesn't come. And active treatment like antibiotics also you can try. That's all. That minimum treatment we have to give. Ventilation, I'm not talking. In this case, if oxygen is more than 90, okay, I don't think patient need any ventilator support. That's my opinion, and more opinion welcome.
There is a chat like, we don't believe in prolonging the life, but quality of life. But definitely the decision lies in the patient and caregiver's hand. And Dr. Bikram is telling patient relatives may sometimes pressurize for ventilatory care, difficult scenario and ethical dilemma. Yeah. Dr. Megha, I think you may have more experience in your setting where relatives ask for ventilatory care. So how do you deal with those conversations?
So yes, especially, in scenarios like non-oncology, when we are dealing with non-oncology palliative care, things are a little more different than oncology, because such patients have, been through such episodes earlier in their life, and they have been through sometimes even ventilation, and they have come out of it. And telling them not to go for ventilation is not really done here. So what we do is we open up both the things for the patient, tell them how the curve is. The curve would be like this. There will be ups and downs in the curves, in the trajectory of COPD, even for that matter, cancer. So there will be good days and bad days, good days and bad days, and there will be episodes when they will come out of ventilator, but one of those episodes will be when the patient will not be able to make it. Right. So we need to tell them in that with great empathy that, okay, this is what we have in platter for you, that you may go in for ventilation, may not. Right. However, here, if we are talking just about the ventilation, yeah, this is what it is. We must give all the options to the patient with their pros and cons, and let them decide and help them decide what should be good for that particular patient, right? That is how we manage such situations in our setup. And about this question, of course, if delirium is making his quality of life poor, I think we must correct the sodium levels and orientation protocols and those things. And fluids, antibiotics, these are minimal things which we can improve. So let the natural course of the disease take place with minimal interventions for the quality of life of the patient. And however, when it is some invasive intervention like ventilation, we must intervene, give them all the options, and tell them what to expect out of it.
Thank you, Dr. Megha. I think, Dr. Vikram, I understand that it's a ethical dilemma or very difficult conversation to tell them that ventilator might not be useful. But I think we have to have that courage to have that conversation, at least from now onwards. Like I remember, I understand that we had a session from Dr. Rajan where she's telling exactly the same thing, because patients with COPD might have gone through it like several times in the past. So second time, third time, sit with them and ask, next time when it is happening, what do you want to do? So these conversations should start from the beginning. Maybe 1 or 2 times they might go through the aggressive management, but at some point of time, I think we have to keep trying. Yes, Dr. Vikram, please.
Yeah, absolutely right, ma'am. And in such scenario, we may persuade the patient and the relatives for home NIV. That is also an option.
Yes, for many may not, because in your setting that might be a possibility, but when you come to a setting like ours where people can't maintain all this at home, and so there is a question on why ABG was not done. I have never done that in my entire 10-11 years in palliative care, because that's not even an option for us when you go for a home care setting or in the community. Whatever minimum investigations we can do, that also we are unable to. Like the patient will be so deteriorated that you can't just think about like what Dr. Ravi Kiran is mentioning. It's like basic things we may be able to do, and just looking on whether. So I preferably ask the patient, are you breathless? Are you feeling breathlessness? That's the most effective way of diagnosing or whatever criteria than checking for it. Like just I ask, sometimes we feel they are breathless, but when you ask, they say they are fine. So it's very, very subjective. So it's important to ask and score. Like same with the pain. I ask them to score, like how far is severe is your breathlessness, and then I might start a low dose of morphine, and then ask them again how good you feel right now. That's like, but it varies from setting. I understand when you work in a corporate sector or in a multi-specialty center where you have the opportunity to do the investigations. But again, Again, I think whether the investigation is going to make a remarkable change in the management plan for advanced COPD, that's one thing that I would consider before. So there was a workshop which happened last few days. So there was a question how to teach medical students on financial implications of medical practice. So one activity which is suggested by the faculty members where we'll tell them to go and find out the price for each medications and the investigations as an activity. Let them come back with it because they don't know how much it costs. No clue. So we tell them you go and understand how much all these things cost. So then there is a sense like what you are writing and why you are writing. Is it going to change the management plan? Just I'm not telling that you should not do anything, but then just give a justification why this particular investigation I want to do now, what change I'm going to make after knowing the results. Is it going and how it is going to impact the quality of life of this patient? It might be different for someone which is like in a completely reversible stage of illness. Not, I'm specifically telling about this advanced COPD with multiple exacerbations in the past and everything. Yeah. And any other comments? I'm sorry, I just took a lot of time. And Dr. Bikram, I'm not disagreeing with you at all. It varies from setting to setting, but sometimes we just need to discuss the pros and cons.
Yeah, so NIV, many time in our setup in corporates, NIV they consider as a mandate, if the patient has falling saturation, they consider as a even if the patient has given a consent for, do not intubate, which our ICU setups really love to take that consent of not intubation. But NIV, we need to consider that NIV really deteriorates the quality of life of the patient. They are not able to communicate. They are not able to, that tight mask really abrades their skin around all this area. So NIV does not come just like that to the patient. It really has an effect on quality of life, and we must be sure that we are helping patient achieve any good quality of life before prescribing that.
So I think there is a third question, like about family members. Like, how should we deal with the family members here? Because there will be a lot of element, as rightly said by Dr. Pitchum. There is a lot of guilt also, like I'm giving up on my loved one. Shall I give up? Can I just let them die? Are you not doing anything? At least can you give something? These kind of questions you might have, you might hear. Right, Dr. Bikram, I think that's the sense behind the question. Like, how can I just give up on
Absolutely right. Yeah. Absolutely right. Yeah. It's sometimes difficult to deal with the patient relatives than the patient.
Yes, yes. So how do you actually deal with that when they ask such questions, like in your setting, Dr. Bikram? Like, how do you, what do you tell them?
Yeah, we tell them that it is really not going to be very fruitful for the patient, and we explain in detail about the pros and cons. And as Dr. Pruthi told, that NIV also comes at a cost and how it is not going to improve the quality of life. That's how we explain, but still sometimes they don't yield to it, and we have to put the patients on ventilator.
And are these patients conscious enough to have a conversation generally, or they'll be like?
No, generally they are so frail that they are not in a state of active conversation.
Yeah, yeah. So I think that comes like maybe we might be getting them really late. But if you happen to get these patients, start seeing these patients much early in their trajectory, it is best thing to have the conversations much earlier than like the patient can't really talk what they want. But unfortunately, we get the patients at that time where they can't express themselves. But I think the key question might be why the relatives are stressing upon all these interventions, because ultimately they want their loved one to be comfortable. Sometimes they want the society to be like, I've done everything possible. Otherwise, people will ask, why can't you just spend money on your loved one? So that is another context. But in general, they want their loved one to be comfortable. That's why they are asking for more. So, yeah, if we can assure them that they can be comfortable, things might be different. Dr. Chaitanya, do you have a question, please?
No, I just had a comment. What I usually do when I'm working in the ICUs is when I see that the patient is deteriorating and we have a choice to make between the duration of life and the quality of life. At that point in time, we can have this discussion telling them how the duration and quality may not be related now, and what would the patient would have liked if he was in his or her own senses, and what decision that patient would have made, and not you as a person. You don't have to make that decision. What do you think he or she would have done? And I would usually not look for answers immediately. I would give them some time to breathe, maybe talk to someone who is much more senior in the family, or someone to whom they go for advice, and then maybe have this conversation after a few hours or a day again.
Thank you, Dr. Chaitanya. Any comments from you, Dr. Megha?
Yeah, just one comment. Two things when we are taking decision, or explaining, when we are talking about that, the caregivers, they keep insisting on ventilation or any aggressive measures. First important thing is let the patient take the decision if they are in that state. And second important thing is let this, come from the primary physician. We as palliative care physician come a little late in the trajectory of onco or non-onco patients. So when their primary physician tells them, okay, it's time now that, we do not again do that, it is time that we may not ventilate the patient. I know the patient has come out several times. And when it comes from the primary physician, patients, they and caregivers, they tend to do and they understand it better rather than when we tell them, because we have met them once, twice earlier. That is what I have seen in my practice.
Yeah, that's very true. That often happens to us also. Even in the wound, unhealing wound, they come and they say, no, the oncologist told this, you apply medicine and then it will be healed. And then now you are telling that it is a non-healing wound and I don't want your service anymore. Then I write to the primary physician. I think it's time to have this conversation. Would you like to have a conversation together? Some people respond like really well. They may want to have that conversation, or I'll send the patient relatives to the physician and I'll write a letter, kindly have a conversation on the prognosis, because so they believe their primary physicians most often. That's why we now are aiming on like we have a few courses specifically for, like, for example, we are aiming at pulmonologists to start this conversation much earlier. And many of them, we understood from the last, we completed 3-4 sessions with them. Many of them want to have that conversation from the beginning and they didn't know how. So that's what I understood. They know that this is going to be a bad prognosis. They might end up really bad, but then they don't know how to talk about it. So that's one thing that we can start talking to the primary care physicians, their referral doctor, and then ask them to talk to them. Maybe one way of getting there. Yeah. So I think when Dr. Chaitanya was telling, it's very important question to ask them, even in delirium, when someone wants to tie them up or continue the intervention, even then they are delirious. It's the very important question to ask the caregiver. If he was conscious and like oriented, will he be wanting the same? What would have he opted for? That works many a times. Like in many patients, I do ask the same questions. What do you think if he was alive and he would want this to happen, or will he want something else? Then they start thinking, okay, yeah, that is true. But they keep arguing, of course. No, but he's sick, right? So I have to do something. But still, that's a very important question that you can start the conversation. They at least start thinking from that point. How to go ahead, like, is it something, they go back, they may not respond then, but they go back, they take some time and think, am I doing the right thing? Are there any other questions specifically? I know that we slightly moved out of delirium topic. We have a whole session on end of life care by people who are actually working on the legal aspects of end of life care. So we'll have detailed conversations about this in that session. But anything pertaining to delirium, we'd like to see if there are any questions. We'll quickly answer that, or yeah, we can wind up today's session.
I have no idea about pediatric care, but does the symptom happen in children as well, especially in terminal stages?
You mean delirium, right?
Delirium in children, yes. Does it
Dr. Megha, do you have any experience in children with delirium?
So not really. I do deal with children, but not many. As far as my knowledge is concerned, I think they do have delirium in pediatric population too, but I've not really catered to many delirium in children, but they do.
Yeah, that's what I also know. They do have delirium, especially with the terminal advanced illness. But I'm not sure about the management part of it, like the medications and the dosages. So, Dr. Bikram, would you like to perioperative you have seen. So what medication do you use in children for delirium? I'm not sure about the home care setting or in a hospice setting. Usually pain is the most common cause for delirium in children. Yeah.
Yeah.
Relief. So I'm not sure about the antipsychotic medications in children, but I can just ask some specialist. So there is another question. How do we differentiate delirium in a mentally challenged children?
I think something like, age appropriate mini mental scale examination, such things can be done to differentiate.
And maybe ask the mother about the sudden change, like it should be already acute usually. So you can ask them, like mentally challenged, they will have, the mothers or fathers will know like how they have been, and sudden change in something can be one thing that you can ask for. And if you suspect delirium, like ask whether they have dreams, people coming in dreams. They say dogs coming in dreams. I can see cats walking around me. So in dreams, even if they are not aggressive, it's very important to ask, do you have bad dreams? That's what I ask usually during the rounds, especially when I start with morphine. Do you have bad dreams? Even though they are like blatantly delirious, like aggressive, they might say that I can see someone, I can hear someone talking to me. He was right there, standing right there when I was sleeping whole night. So all these questions can be asked. Do you see people around having some bad dreams? Yeah. Thank you, everyone, for the questions and the discussions. Thank you, Dr. Megha, for the wonderful session and the discussions followed by that. Thank you so much for your time from your work. Thank you so much, all the participants, for contributing towards the discussion.
Thank you so much. It was a pleasure. Thank you. Bye. Have a good evening, everyone.
Thank you, Dr. Megha, for joining us. And thank you each and every participant for making this session so much interactive. And hoping to see you in the next session with another interesting topic and eminent faculty. This is Sri Priya along with Dr. Sridevi Warrior and Dr. Megha signing off from the Deep Seco Hub. See you in the next session. Bye-bye.